Thank you, Corey. So I just thought I'll give you a broad overview of where we are going to be in the next few years and what sort of strategy we'll be taking in terms of lung cancer research. In fact, there are over 150 drugs being evaluated in lung cancer, so it's really not logical to go through one by one. And I don't have any major conflicts here. And I just want to say briefly a few words about Mark Green. Mark Green passed away a few weeks ago. Mark, as many of you may know, was a leader in the field of lung cancer, a remarkable human being to begin with, and a wonderful teacher, great mentor, a terrific clinician, and perhaps the greatest moderator of all times, and many of you have benefited. What really impresses me about Mark when I think about him, he not only was my dear colleague, a mentor, and a friend, he could remember you from years ago meeting and talk about you in personal terms. Mark's loss is a true loss, and he died of plasma cell leukemia. I had the privilege of talking to him a few weeks before he passed away, and he sounded as cheerful as he always did. And we all will miss Mark. And so moving on to this, we have actually now found a number of new targets in lung cancer. In fact, the same pie chart done many years ago would have shown about just one big segment, that's KRAS mutation. 10 years ago, we recognized the presence of EGFR mutation. About 7 years ago, ALK fusion, and then over the past few years, we are discovering this. I put this slide for a couple of reasons, and this is a work from our Cancer Genome Atlas project, came from about 230 adenocarcinoma specimens, where we found nearly 75% of them had actually a targetable alteration. And one thing you need to know is that when we do these studies, it's very hard to pick those unknown unknowns. It's very easy to go and look for KRAS mutation, ALK fusion, if you know that they are known variants, known genes that are known to play a role in cancer. But when you're in the business of discovering new genes that actually have not yet been recognized to cause cancer, it's not that easy. In fact, we rely on algorithms. While these things have improved, we are actually trying to figure this out. Essentially, we are trying to pick needles in the middle of a haystack, and it's a very daunting task. So daunting that quite often, when you give the same data set to multiple institutions, or at least the two major genome institute, one in St. Louis, one in Boston, the actual output may not necessarily be the same. They'll be close, but they won't exactly be the same. These algorithms, much like your Google search, is getting better and better. But then, in fact, we will actually find more and more as we get better and better. So I don't think we could say that we have discovered every single important targetable alteration. So that's the point I just want to make. But then we have plenty of work to do even within here. A couple of important things we reported in the paper a few months ago was that in a good number of these patients, NF1 loss was important, neurofibromatosis 1, and this could potentially be targeted. And even if there is not an oncogene, a tumor suppressor loss could potentially be targeted. P53 mutation, it's not just one P53 mutation. There are many types. Broadly, they can be categorized into disruptive mutation or non-disruptive mutations, the one that just causes mere loss of tumor suppressor, the one that actually gives oncogenic function. And there are many novel ways one could potentially target this, and these are approaches many of us are pursuing. And also, there was a very novel alteration of a MET gene was found in 2% of the adenocarcinoma patients. And in fact, what happens is that one particular exon gets missed, and this is an exon important for MET inactivation. So in the absence of that inactivating portion of the exon, what happens is that the MET is constantly under signaling. And in fact, these patients are very sensitive to crizotinib. I have treated a couple of patients with exon 14 skipping event they respond well to crizotinib. And so clearly, we are actually going to be discovering many more as we go along with adenocarcinoma. Same with squamous cell lung cancer. Squamous cell lung cancer will be a little bit more difficult because we don't see the canonical or the classical oncogene alterations, and we do see some copy number alterations, amplifications. And by the way, we've been focusing a bit too much on these single nucleotide variations or mutations, but then we'll be looking more and more about these amplifications, overexpressions, where the genes or the copy numbers are significantly altered. So these things are not that easy to pick up on the routine things, although the TCGA data does include the data does include all those things. And again, the other important point I want to make is that we have collected over 1,000 patients and samples, and we have just reported barely on about a third of them. So we'll be reporting on all 1,000 of these lung cancer specimens, 500 adeno, 500 squamous later this year, and we hope to discover many more of these alterations. The other problem we have in cancer in general is that we see a lot of these novel fusions. In fact, if you go back and read the original paper on the EML4-ALK, this was really discovered through a sheer stroke of luck. That would probably have been discovered in the later day with the sequencing. But in that day, 7 years ago, that particular sample they were working on had happened to have this fusion. Otherwise, it would have never been discovered. But the modern sequencing technology would have picked up by now. But then we often find these fusions present in one-off specimens. That is, you never see again. You see in one specimen, you never see it again. And in fact, I'll just give you an example. This is a whole genome and transcriptome analysis, not from TCGA, from our own analysis of just 17 patients. We found over 60 fusion genes. Many of them were in frame, and many of them are likely to have some functional effect. But teasing that would take years of work. And I think this is going to be one of the areas of great interest in the coming years. When we put together all the cancer genomes, we'll be looking at the transcriptomes in a very systematic fashion. We'll find, perhaps hidden in this, a number of ALK, ROS, RET kind of fusion genes in the coming years. And I think that's certainly a reason to be hopeful. And I just thought I'll address a few areas, and you may have heard many of these things. Some repetition is not a bad thing. And I just thought I'll highlight some topics that may be of interest to you as a practicing physician. One is you see KRAS mutant patients all along, and what do you do with those patients? And previous speakers touched on that briefly, but I just want to highlight a few areas where I think there is now room for hope. The second thing is small cell lung cancer. In fact, as much as we can talk about non-small cell lung cancer, small cell lung cancer continues to be relegated to the evening sessions or later day discussion or no discussion at all. And I think we may make some headway in the coming years in small cell lung cancer. I'll just highlight a couple of areas. And the third is I deliberately did not put a lot of slides or any slides on the existing studies with immune checkpoint inhibitors. I can just roughly summarize when I get there. But I was going to talk about where we're going to go in the next 4 or 5 years. This, I think, is going to be fascinating, and it may even make the targeted therapy somewhat redundant and not that important, although that's a bit of an exaggeration at the moment. But I think immunotherapy may play a major role. And in fact, pretty much every week there are really groundbreaking papers coming up, and I'll just briefly highlight them, and you will see the promise there. And then I think rightfully, finally, we have changed the paradigm of clinical trials, and our own clinical trial approach has become much more sophisticated, and you may have heard of that, a few of the trials, but I'll just talk about this, and then I'll wrap them all up in the next few minutes. And with all these things, the KRAS mutation is really an important, alteration, not just in lung cancer, but many other cancer. But what is fascinating is that there are different genotypes, and the mutations are not one type. KRAS mutation, you cannot just lump them in one category, and they behave differently. And if you look at this, all the different cancer types where the KRAS mutations happen, there are two major changes. One is the type of mutation that happens, G12C, G12D, or which codon is affected matters. Second, the context in which these things actually occur also matters. I'll give you a simple example in lung cancer. Loss of LKB1, other tumor suppressor, actually may have profound influence on the outcomes in patients with KRAS mutations. If you take further apart, if you take other cancers, the concurrent alterations in other pathways, other lesions that have acquired over time would significantly influence the response to KRAS mutation. That's true for EGFR mutation too. You can have a classical exon 19 deletion EGFR, but you have a concurrent loss of PTEN. In fact, you don't respond very well to the EGFR TK inhibitor. So the context in which these mutations happen would profoundly influence how these agents would work. So you have to keep that in mind. We cannot just simply lump them all together. And even within the KRAS mutation in lung cancer, even without the absence of any other concurrent key alterations, the specific genotypes may have different outcomes and may have different response to therapy. And, Ronnie, I think, talked briefly about MEK inhibitor, and but I'll just briefly, that reminds me of an interesting anecdote I should tell you at some point, and maybe I'll tell you now. And actually, talk about the flat world we all live in. And I want to say a year ago, I saw a patient from Indiana came to see me for a second opinion, and this patient is a farmer, and the wife came and had very little interest in most of what I had to say, and I actually kept it very simple during the discussion. This patient had KRAS mutation, and as we were talking about, I just thought I was losing them, somewhat similar to some of you I see right now, and I thought I was losing them as I was talking, and towards the end, as I was mentioning about a trial, the patient's wife's ears perked up a little bit. She leaned forward, gave me a disapproving nod, and then really squeezed her eyebrows and leaned forward and suddenly said, "So, this is not a MEK inhibitor?" And so the patients are that sophisticated, I could have expanded this a little bit more. I didn't want to say it. You guys didn't laugh. That's okay. And so the amount of the knowledge that people have about the MEK inhibitors and other thing is quite profound. And so that's one option for our patients. And the other option is the cell cycle inhibitors. And we have actually the CDK inhibitors that are actually being developed, and as you know very well, Abemaciclib is approved for breast cancer. And these are selective CDK4/6 inhibitors. There are a couple of compounds actually of great interest. One is this Lilly compound, CDK4/6 inhibitor, also known as Abemaciclib. And this is actually an oral drug, fairly well tolerated. And in fact, if you can see this, this is in a small study, you can see that small number of patients actually had a nice response. And but what is interesting is that a good number of patients who had KRAS mutation had either shrinkage or actually had a nice tumor shrinkage or a stable disease. And this is actually the first time, at least I have seen, a reasonable looking, if not a dramatic waterfall plot, reasonable looking numbers without a chemotherapy. And so this agent is being studied in a randomized setting. Patients with KRAS mutant non-small cell lung cancer get randomized to Abemaciclib or erlotinib. The choice of the control arm is, I have to say, is controversial, and I'm not sure that I agree with that. I would have designed it with Abemaciclib, a CDK4/6 inhibitor, versus standard of care therapy. We know that erlotinib is not a great agent for a KRAS mutant lung cancer, but leave that aside. But this is one study that is currently ongoing, and some of you may be participating in this. And Abemaciclib, a similar drug made by Pfizer, CDK4/6 inhibitor, is part of the LungMap trial, and it's also being tested in a UK trial, and where patients with KRAS mutant lung cancer, along with a few other biomarkers that are supposedly predictive of efficacy with this class of drugs are being tested. I think it's very important to appreciate that at the moment we don't have a very clear biomarker on who would respond well within KRAS mutant lung cancer with CDK4/6 inhibitor, but I think certainly this is actually look very interesting, and I think the studies have to be done to clarify this. Apart from the MEK inhibitor, going after the CDK4/6 is certainly an important thing to approach. For this. The other thing you need to keep in mind is that the PD-L1 inhibitors or the PD-1 inhibitors have shown activity in KRAS mutant lung cancer. In fact, the KRAS mutant patients are often those with a history of tobacco smoking, and those with tobacco smoking have a higher number of mutation burden, and the higher mutation numbers may predict for response to PD-L1, PD-1 inhibitor therapy. So at some point, you could potentially see a combination of immunotherapy with targeted therapy or in some kind of a sequential fashion. So I think for the first time, we are looking to see some movement in this area with the KRAS inhibitors, either with the inhibitors of MEK or CDK4/6 or immunotherapy in combination. So this is the MEK pathway, and in fact, the phase 2 study showed 0% response rate with docetaxel alone in the KRAS mutant patients, and a reasonable 20% response rate with the combination. And so these results with, this is actually selumetinib with the docetaxel or docetaxel alone. So I think we have a few options for this population. And there are also other drugs are being explored here, and there's a massive effort currently ongoing to go after the RAS driven cancers. And so clearly I think this is more encouraging than what has been in the past. The second thing is small cell lung cancer. The small cell lung cancer, I'll just give you a couple of studies and then I'll tell you where I think this is heading towards. This is a study you may or may not have seen published in Clinical Cancer Research from the Memorial Group showing the response rate with temozolomide. And temozolomide, as you know, it's a kind of a non-classical oral alkylating agent that actually goes after guanine in the DNA. And if you have the MGMT that can repair this lesion, in the absence of MGMT, repair the DNA damage sticks, and these cells actually undergo apoptosis. So the MGMT silencing or low MGMT would predict for response to temozolomide, and that is true in glioblastoma multiforme, both in single institutional studies and also through an RTOG study. And there is some hint that MGMT is hypermethylated in small cell lung cancer. There have been some anecdotal reports of response for in small cell lung cancer, and temozolomide causes blood-brain barrier, which is a huge problem in small cell lung cancer. So for these reasons, rightfully, the Memorial Group pursued this, and this is a small phase 2 study where patients got actually the daily regimen, 75 milligram per meter square of temozolomide, 21 out of 28 days. And as you can see, the response rate is not too bad at all. And even in resistant patients, responses were seen in brain metastasis. And the side effects are fairly tolerable with cytopenia and some nausea. So this is not an unreasonable thing. Clearly, we need to do better than that. But the question really is, can we actually look at this more carefully? Can we identify a group of patients who would respond well? In this very small study, there was a trend towards MGMT expression, that is low expression, with response to temozolomide. So really, if you can expand on that, you could potentially actually use this as a base regimen. So one study currently ongoing is using temozolomide with a PARP inhibitor. Why PARP inhibitors? When small cell lung cancer, in fact, Lauren Byers from MD Anderson showed that the PARP is actually overexpressed in small cell lung cancer, and in fact, by inhibiting the PARP activity, you could convert a single-strand break into double-strand break, and you could potentially cause cytotoxicity. It's not been clear whether the PARP inhibitors would be a major player by themselves, but the combination is being tested in a randomized multi-institutional study where patients will get temozolomide alone or temozolomide with ABD888, a PARP inhibitor. And so there is this dual movement that is currently ongoing with in small cell lung cancer, looking at these kinds of combination. And there is also a lot of interest in studying immunotherapy in small cell with immune checkpoint inhibitors. And those some studies are currently ongoing and a few more are being planned. One problem is that we have to be careful. Small cell lung cancer is a disease with some paraneoplastic syndrome. Some of them are immune-mediated. It's potential that sometimes the immune checkpoint inhibitors can aggravate this paraneoplastic syndrome, so we need to be careful about this. But there have been anecdotal reports of fantastic responses in small cell lung cancer with checkpoint inhibitors, and so it is something that's another option for patients with small cell lung cancer. Talk about mutation burden. Small cell lung cancer is to the right of melanoma in terms of mutation burden, and if that is the important determinant, clearly small cell lung cancer has a better chance to respond to checkpoint inhibitors. But like everything in life, it is not so simple as just the mutation burden alone. A lot of other things would dictate response to immune therapy. So only time would tell whether immune therapy would be a player in small cell lung cancer. And I just want to talk a little bit about the immune system. And this is actually a work done by my colleague Bob Schreiber at Washington University. And if you just step back, you have to ask yourself, why do these immune checkpoint inhibitors work in cancer in general? As it turns out that as the cells transform, the transformed cells express some of the altered proteins on the cell surface. I'll give you an example in lung cancer, tobacco-related lung cancer. The average number of mutations is about 300 in the coding region. Of those 300 regions, about 300 tumors, 300 altered mutations at the DNA level. About a third of them are expressed at the RNA level, and a few of them are very antigenic, what are called the neoepitopes, that the immune system could be using it to go after. Probably in reality that happens a lot, and that probably is an important pathway for eliminating the newly developed cancer cells. And so that's the model that Bob Schreiber put forward, which is now fairly widely accepted. There are three phases in cancer, birth and evolution. The first is this phase called elimination, where any of those altered cells are eliminated by the tumor cells, and perhaps many of us developed a few cancer cells here and there. They were eliminated by our intact immune system, and you never hear anything about this. Unfortunately, it doesn't go that way most of the time, or a good number of times. And then there is a phase where the tumors actually escape the immune system's attention, either by producing proteins like the programmed death ligand 1 or PD-L1 or other inhibitors of the immune system, or the T cells get exhausted for various reasons, or for some reason the tumors evolve in a way that they really don't have this antigenic epitope, so that they can happily grow, not inviting the immune system's attention. So there are very many reasons why the cancer cells can grow, ignoring the immune system's watchful attention. And so at some point, what happens, the equilibrium phase evolve into what is called elimination phase, and that's when our patients come to see us, and where one of the mechanisms, if not the main one, is the PD-L1 overexpression. That's why when you actually cut down the PD-L1, suddenly what happens, the T cells can go into the tumor cells and attack them. In fact, some of the studies, you can literally see the T cells at the edge of the tumor migrating into the tumor upon using checkpoint inhibitors, and actually literally attacking the cancer cells. And over the last week, I should say, what is obvious is that a few things matter. One is that mutation burden matters, and it turns out that if you have mutations, about 170 or so in the coding regions in lung cancer, this is the work done by Naya Rizvi and Tim Chan from Memorial Group and Ton Schumacher, and showing that if you have about 170 or so mutation per tumor, there's a greater chance of disease control with immune checkpoint inhibitors. The other important thing that may matter is that the presence of T helper cells, and T is T8 cytotoxic cells, and also the T regulator cells have to be dampened. So there's a combination of all these things I think are important, not just the mutation burden. And then also there is the repertoire of the antigenic epitopes that are also very important, and the radiation may perhaps enhance the diversity of these epitopes, and that's probably one reason in some situations the radiation therapy induces the abscopal response to immune therapy. So I would refer you to a couple of nice papers that have come out in the last week. One was published in Nature this week, another was from Science. The Science paper is from the Memorial Group, and the Nature paper from the UPenn group, actually talking about the synergistic thing with radiation therapy, with wonderful animal models explaining a lot of things that we observed in the clinic before. And the other area where I think we're going to be seeing a lot of activities in epigenetic therapy. There are now a lot of interesting things that are coming up. So the epigenetic therapies, it's possible that using epigenetic therapy, you can uncover some antigens that can actually synergize the immune therapy. This is actually a study actually done by Steve Balin and Charlie Rudin at Memorial at Hopkins, and where patients actually got epigenetic therapy and then progressed and then went on to get actually immunotherapy. And it turns out that those who had epigenetic therapy had not only had a dramatic decrease, also a lasting response to immunotherapy. So I think in terms of making the 80% non-responder to checkpoint inhibitors respond, one strategy would be to perhaps prime them with epigenetic therapy. And again, I'm not saying this will work. This is an area that's going to be actively investigated and will be studied. The other one is almost, you would think it's in the realm of science fiction, but I would argue that it is not there. It is actually happening right now. And, in fact, there are two papers. The one was from our group, published a couple of years ago, and showing that you can actually create in animal models, you can sequence the tumors, you can identify the epitopes that the immune system can go after. And these antigens are not your traditional driver oncogenes. These are actually very undescribed, rare cell surface markers. And the more recent one is a patient with hepatobiliary tumor who actually responded to TIL therapy, and it turns out that the activated T cells were seeing this ERBB2 interacting protein, and in fact the tumors regressed specifically when they gave a very enriched T cells going after this ERBB2 interacting protein. And so this is one way to actually customize therapy. So we have treated with three patients where we actually take the tumor cells, sequence them, and we find the expressed antigens, and we have this in silico prediction algorithm to find which are antigenic epitopes, and then we customize T cell and dendritic cell vaccines, take the patient's T cells, expand them, and give it to them. In other words, the sequencing is not the end result. The sequencing is the beginning of the work to have the customized T cell vaccine, and then we are going to start studies in combination with checkpoint inhibitors to augment those therapies. So there are a few ways we can actually harness immune therapy as we go along. In terms of clinical trials, you know about Alchemist trial. This is for early stage patients where we're going to be looking at 8,000 patients with EGFR mutational ALK positive lung cancer. We'll be doing targeted therapies. We ask your participation here, and we'll also be doing studies using genomics. You have this umbrella and basket studies that are ongoing, and these all will actually, some of them will undergo genomic analysis to fully understand the molecular mechanisms of relapse and response. And we have already talked about the master protocol. You don't have to go over this again. And then, even though this mutation burden is quite daunting, the genome instability itself may be a target, and there are many approaches going to be pursued in the coming years. And in fact, we are about to launch a 10,000 patient lung cancer adenocarcinoma sequencing studies to understand every single alteration that actually causing tumor. And then over the time, we will actually looking at tumors in multiple regions to understand the heterogeneity and the mechanisms that contribute to tumor metastasis, as well as the evolution of the clones, as you see in the fish mouth plot, where you can see the tumors with multiple clones, single founder clone to begin with, multiple clones at diagnosis, elimination of most of the clones during treatment, as you see, and then expansion and the significant overrunning of this tumor population with an acquired clone that kills the patient. To understand how the tumors evolve, we'll be doing serial biopsies to fully understand how these mechanisms of resistance evolve in the coming years. With all these things, we'll go through very systematically, and this is the Charlie Swanton slide showing that some tumors like lung cancers are more like this babao tree, and where you have really evolved over time and that require multi-pronged approach, surgery, radiation, immunotherapy, targeted therapies, and that's how we'll be going after that. I think the future looks very promising, and we'll be using more and more complex therapies, more and more expensive therapies, and we'll deal with that problem later on. Thank you very much.